Are you
We are good to go.
okay? Thank you so much. Good evening, everyone, and a very warm welcome to another session of iTrust webinar. I'm Dr. Kunal Shrosso. I'm a senior medical manager for the diabetes and nephrology at Wockhardt. And today, it's a special day, definitely. And I would like to start by saying and expressing my gratitude and warm regards to one and all those who are out there working really hard day and night just to save their patient, just to make their lives little better, little longer. To all the doctors out there, I, on behalf of my medical affairs team and the whole Wockhardt, we wish you a very happy Doctor's Day. Now, moving ahead, iTrust. iTrust in itself, it's a complete sentence. It states that where our trust lies. For us, and this name iTrust actually is for insulin. We trust in insulin. Indigenous insulin, made in India. And that is where our trust lies. Today, we would also like to talk about how around 2 decades back, we, the Wockhardians, we took over this mantle that we should bring insulin to India. And not by bringing, we means indigenously developing it here on our soil. In fact, we are the third in the world who started producing insulin from the scratch to the final product. And yes, we are really proud about it. And that is why we trust on it. So it's made in India, the indigenous insulin. Now, iTrust webinar is a series of webinars where we talk about the nitty-gritties, the things those are essential, because we all know it has been a centenary year of insulin, 100 years down the line. And yet, every day we find something new to talk about insulin. It has been the mainstay of the management of diabetes. And yet there are so many things that we all can learn every day whenever we start discussing about it. And so is today's program, how it is shaped like. Now, to walk us further into the program, to the agenda, and take us forward, I'd like to invite my colleague, Dr. Amarjeet Singh, to take over. Dr. Amarjeet, I'll hand it over to you.
Ladies and gentlemen, this is Dr. Amarjeet Singh from the Wockhardt medical team. Good evening and warm welcome to the iTrust webinar. We are delighted to have our two distinguished speakers, Dr. Ruzulbhi Meswani and Dr. Puspa Saravanan. They are both exemplary medical professionals who have dedicated their career in improving patient outcomes and challenging conventional wisdom in their respective areas of expertise. Dr. Ruzulbhi Meswani is our first speaker. He is an esteemed authority on the topic of managing hyperglycemia in the non-critical care setting. 1 minute. Dr. Ruzul Meswani is the senior consultant physician and preventive diabetologist in clinical practice, more than 30 years of experience. He is the joint organizing secretary of Asia Oceania Conference on Obesity in 2009. He is the founder member of AIAARO, that is All India Association for Advancing Research in Obesity. He is the concept innovator of Atma for You, a center of excellence for prevention and management of diabetes, obesity, and cardiometabolic disease. He has several awards on his name that includes Bharat Jyoti Award, Bharat Ratna Award, Outstanding Citizens Award, Best Citizen of India Award, and Gujarat Gaurav Awards. He is the author of various scientific publications. Our second distinguished speaker, Dr. Puspa Sravanan, will be addressing the myths surrounding the use of insulin in the management of diabetes. She is the Associate Professor in Institute of Diabetology at Madras Medical College. She is Senior Consultant Diabetologist in VR Diabetes Center, Chennai. She is also visiting consultant at CPCL, Chennai. She is the teaching faculty at Dr. MGR Medical University. She is also managing editor in Journal of Medicine and Science. She is the speaker in various national forums, and she has been awarded as the best doctor from MMC Chennai. So without taking much time, I will request Dr. Rajul Meswani to take over the first presentation. So over to you, sir.
Thank you. Is my slides visible?
Sir, you want to share your slide or I should run?
I don't mind if you can share it. I'll try sharing from my side if possible.
Okay, I will stop, sir.
Okay.
Welcome, Puspa ma'am.
Screen visible?
No, sir.
I think Amarjit, you only do it.
Okay, sir.
Yeah.
You stop sharing, sir.
Yeah, I'll do that. I can't see it. So at the outset, I thank, first of all, Amarjit, thank you for your kind introduction. At the outset, I thank Dr. Kunal Srivastav, Dr. Amarjit Singh, Vishwas Gaurav, Nirmal Kumar, and the whole of Wockhardt India for inviting me as a speaker in today's iTrust webinar. Ladies and gentlemen, the name of the CME series, iTrust, is very appropriate because Wockhardt has been continuously serving mankind since the last 20 years. So they write 20 years of trust, 20 years of innovation. Newer innovations, excellent quality products is what Wockhardt stands for. But the most important, and I feel the most significant point about Wockhardt is that this excellent quality products come at a very affordable price. So it's just not I trust, it is all, we all trust you, Wockhardt, and we appreciate and salute you today on Doctor's Day to continue this noble gesture with more innovations and affordable products. Next slide. Yeah, so my dear friends, today's topic is managing hyperglycemia in non-critical care. This is a topic which you guys will realize in the next 15 minutes or so of my talk, why it has a very special significance. So why so? Let's see. So coming to this first slide, let's come to some statistics which we are all aware of, that diabetes is the biggest killer among all the non-communicable diseases. 1.01 million deaths due to diabetes and its related complications annually, translating to one death every 8 seconds. Going further, one should appreciate that diabetes is an increasingly prevalent diagnosis among hospitalized patients, and many patients have unrecognized diabetes. So we have two groups here. The first group is of those patients who are known cases of diabetes prior to their hospital admission. And the second group is totally unknown. First time, a newly discovered diabetic patient when admitted in the hospital. Now, glycemic control in the hospital should become a priority both to enhance quality and patient safety and to reduce costs related to the length of stay. That's because approximately 38 to 46% of non-intensive care unit hospitalized patients have diabetes mellitus. And what is very striking here is that this hyperglycemia is generally associated with an increased risk of mortality, complications, and length of stays. As seen clearly in this slide, the mortality rate of inpatients with an hyperglycemia of new diagnosis is huge, 16%. As also the rate with a prior history of diabetes, that is 3%. Both these rates, if you can see, are much higher and significant than hospitalized patients with normoglycemia, where the rate is just 1.7%. So what's the bottom line? The bottom line is very simple. Treat hyperglycemia quickly, early, and aggressively in hospitalized non-ICU patients. Next slide. So this slide will ring the alarm bell, my dear friends. Just to point out to you, there was an adjusted analysis study indicated that in non-ICU patients with hyperglycemia, it was very clearly seen that glycemic variability during hospitalization is independently associated with longer length of stay in the hospital and increased mortality. Look at the figures, my dear friends. This adjusted analysis result indicated that for every 10 milligram per DL increase in standard deviation, length of stay increased by 4.4%. For every 10% increase in coefficient of variation, length of stay increased by 9.7%. So also for every 10% increase in standard deviation, relative risk of death in 90 days, 3 months, also increased by 8%. So the carry-on message, my dear friends, is to be alert and bring down the hyperglycemia in non-critically ill hospitalized patients also. The same way you would do for an ICU admission, because everyone is at their utmost vigil when it comes to ICU admissions. But in non-ICU patients, addressing hyperglycemia now becomes of prime importance, as we just saw. And since we just saw, the mortality rate is so significantly high. Next slide. So having said that, let us come to a very simple algorithm recommended by the American Diabetes Association to manage hyperglycemia in a hospital setting. It's very simple, and I'm very sure you all must be following the same. The most important treatment in a hospital setting, therefore, is very simple. It's insulin therapy. So insulin is recommended. No AIDs, they're generally not recommended. In fact, I would strongly advocate that once a patient is hospitalized, please stop the sulfonylurea, especially in the OADs. If the patient is critically ill, the insulin choice would be an IV insulin, because we need to bring down the hyperglycemia fast. Subcutaneous insulin is what we would recommend in a non-critically ill patients. So it's very simple. A very important first step I would like to recommend is to please discontinue OHS, because what happens is that you don't realize the life-threatening hypoglycemia which comes in a serious patient, because he's got other problems. And this sometimes, somehow or the other, especially in nursing homes, smaller nursing homes, it gets missed. Next slide, please. So coming to the glycemic targets for the hospitalized patients, both the American Diabetes Association and the RSSDI recommend that the threshold for starting insulin is anywhere above 180 milligrams. So your target range should be between 140 to 180. Target of 110 to 140 may be appropriate for selected patients where you want to be more aggressive, younger patients, no comorbidities, just detected diabetes with other complications. You need to bring down the HbA1c to 7, less than 7 if possible, 6.5. So these are the people where your target is 110 to 140. But in older people who are terminally ill, they have severe comorbidities, it's difficult to bring that. In fact, you are very worried about hypoglycemia. So what happens is that you are the best judge, my dear friends. So you decide the type of setting of the individual targets for your patients. But on an average, it's about 140 to 180. Excellent. So coming to some practical recommendations when it comes to a non-ICU admitted patient, if a patient is nil by mouth or very poor intake orally, then just a basal insulin or a basal insulin plus a small correction dose would be sufficient. Here, I would like to re-emphasize again that first thing to remember when your patient is hospitalized, irrespective of the reason, stoppage of oral OHS, especially the sulfonylurea group of drugs, would be a very wise first step. The next batch of patients with a good nutrition intake, the basal bolus or basal prandial regime with correction doses whenever required is the universal recommendation. Lastly, coming to the sliding scale insulin regime, this is one thing which I feel very strongly about. This is, my dear friends, totally condemned by all guidelines. And the discontinuation of this sliding scale regime is advised. Today's best message or the most important message, my dear friends, is to take this message today that you are going to stop totally. You're not going to follow this sliding scale insulin regime. You have to stop this regime. There are no differences of opinion in this. There are no two things about it. It's just a big no. So stop this obsolete and outdated regime immediately if you are not following it. Yes, that's what I would like to strongly say when showing you this slide. Next slide. So why, what was the reason? Why is this regime discouraged and advised to stop? Well, the evidence-based answer is in this study. If you can see this slide, the RABBIT-2 trial, which was a prospective randomized trial of 130 insulin-naive type 2 diabetes non-ICU patients, admission of blood glucose was between 140 to 400 milligram per DL. Basal bolus insulin with glargine and gluculin versus regular insulin by sliding scale was compared. So this was the whole trial, the RABBIT trial. The mean admission blood glucose was 229 milligram per DL and the HbA1c was 8.8%. Now, a blood glucose target of 140 milligram per DL was achieved in 66% of patients, mind you. When they took basal bolus, 66% of patients in the glargine gluculin group and just 38% of those in sliding scale insulin group were achieved. Now, which means that almost a double value of number of patients who achieved good glycemic control in the basal bolus arm compared to the sliding scale arm. So this is first most important reason that you must stop this sliding scale insulin regime. The mean daily blood glucose between groups ranged from 23 to 58 milligram per DL with an overall blood glucose difference of 27 milligram per DL. So now, despite you increasing the insulin doses, 14% of patients treated with sliding scale remained with blood glucose of more than 240 milligram per DL. This is where the problem was. There was no differences in the rate of hypoglycemia or length of hospital stay. So this trial therefore sealed the fate of the sliding scale method totally and completely. Next slide. And why, my dear friends, I'm emphasizing to you so much to give up totally this obsolete, wrong, more harmful than imagined sliding scale regime? Well, the answer is very clear. You just see the fact. This is a non-physiological or a retrospective reaction to blood glucose. That's not done. Today's world, poor glycemic control and increased risk of hypoglycemia. See the roller coaster that happens. And you cannot predict insulin dosage requirement. You cannot say ki itna hoega, so therefore you should do this. It cannot be individualized and it is a reactive approach. So answer is very clear. The sad part, despite increasing evidence that supports intensive glycemic control in hospitalized patients, blood glucose continues to be challenging. Blood glucose control remains challenging, and sliding scale insulin coverage, a practice which is associated with very limited therapeutic success, continues to be the most frequent insulin regime in hospitalized patients. That's the sad part. Sliding scale insulin has been in use for more than 80 years, just imagine, without much evidence to support its use as the standard of care. So several studies have revealed evidence of poor glycemic control and deleterious effects in sliding scale insulin use. In conclusion, therefore, sliding scale insulin, the most commonly prescribed inpatient insulin regime, is associated with poor glycemic control and increased risk of hyperglycemia. So the decision you are going to take today is you are going to stop using this sliding scale and you are going to tell others also. Okay, so next slide. So what is the recommended regime to follow? Well, it's the simplest and the best possible time-tested, the basal bolus regime. The superior efficacy of the basal bolus regime compared to the sliding scale insulin regime fundamentally occurs because it's a very physiological way. If you look at it, it's a very physiological way of controlling the blood sugars. We have the basal insulin and we have the prandial as small boluses. So ADA recommends, if you notice, three components. You are addressing the fasting state insulin requirement, bolus, the mealtime insulin requirement is getting addressed, and if required, unexpected glucose elevations or surges, dispose of the elevated hyperglycemia with a correctional dose. So it recommends ADI and RSSDI, all international national guidelines recommend use of basal bolus regimen in patient setting. Implementing this basal bolus therapy in non-critically ill patients will improve glycemic control with fewer hyperglycemic or hypoglycemic episodes. Therefore, to conclude, my dear friends, implementing this in patients will result in substantial improvement. That's what we are looking at, and that's what we are going to follow. Next slide, please. So now coming to this hyperglycemia treatment for hospitalized patients and eating a normal diet. Now this is something which is, I'll simplify it in a very simple way, that if your patient is eating a very normal diet and you need to treat the patient, if it is type 1, there's no question. You are going to put them on the regime that is going on. So whatever the outpatient insulin regimen is going on, you will continue it. But if you must think of a little bit of reduction, because the nutritional intake likely would be more restrictive to the patient. So whether it is type 1 or type 2, you are switching over to insulin. You will continue, if the patient is already on insulin, the same regime with a little bit of reduction of doses, about 25%, 30%, because you are going to be more strict in your nutritional advice. So next slide. Now, if it is badly controlled, so I would like to summarize everything in a very simple way, that you begin basal insulin. Now we all know that how do we go about the basal insulin? So it's always 0.2 to 0.3 milligram per units. Some people start with 10 units. Both are correct, but ideally you start with 0.2 to 0.3 milligram of units per kg body weight. The basal insulin is not just starting an initiation. It is very, very important. And this is a message that every one of us should get today loud and clear, that you have to up-titrate the dose and optimize the dose. So from 0.2 to 0.3 you start with and you go up till 0.5. That's the way basal insulin should be titrated. So when it comes to admitted patients, you are going to start with basal insulin and you are going to give prandial insulins as 0.05 to 0.1 units per kg per meal. So that's the way it is. Now, let's understand a very simple thing. How do you calculate the total daily dose insulin requirement for the body? So it's a very simple thing. Let's go step by step. 0.55 multiplied by weight in kgs. So 0.55 into weight in kgs would be the total insulin requirement. Now we all know that insulin requirement gets divided as almost a 50% dose goes into a basal dose and the 50% gets divided into 3 prandial doses. So 50-50 is the right way to remember. Now, what do you mean by this insulin sensitivity factor? So that refers to the drop in blood glucose, blood sugar level, where the measurement is done in milligram per DL. That's what we do here. So let's follow that. Let's forget the millimoles thing. So how do you do it? It's remember the 1800 rule. So you calculated the total daily insulin requirement by multiplying 0.55 into the weight of the patient. You started basal with 0.2 to 0.3 units per kg body weight. Now you want to know the insulin sensitivity factor of the patient. So it's a very simple thing. The total daily dose, you divide it into 3 parts, the basal and the prandial. Now, 1800 divided by the total daily dose will give you the requirement, I mean, the insulin sensitivity factor. So it's a very simple thing. By doing this calculation of the factor, you would be able to understand how this correction factor means 1 unit of insulin will lower the blood glucose by approximately 50 milligram per ml. So how do you do that? We'll talk on the next slide. Next slide, please. Yeah, so when it comes to nil by mouth, this is how you will do it. You start with people who are NB, nil by mouth. You will have to give basal insulin the way I said it, and the correctional insulin when the blood glucose, remember we are keeping it between 140 to 180. So when the correction insulin is added, you do it. I'll just tell you the calculation, how simple it will be. So I've just noted it down. It takes time. You'll need to have a pen and paper when you calculate this dose. So this correction factor means that 1 unit of insulin will lower blood glucose by approximately that much. So if I put the figure 1700, that's another simple way to do it. 1700 divided by total daily insulin. So the total daily insulin, let's say it comes to about 30 units requirement. Then 1700 divided by 30 brings it to 50. So this becomes the correction factor. That means this is what you will be adding. This is how you will be getting this 1700, 35 units, then it becomes 48. So this is how you will be calculating the correction factor. Now, what is the difference between actual blood sugar and target blood sugar? So that's how you will be adding these doses. So if 1 unit, as we saw, will drop your blood sugar by 50 points, right? And the high blood sugar correction factor is, let's say, 50. Now, if your actual blood sugar that you noted was 220 and your pre-meal, the target that you had was 120, then 220 minus 120 becomes 100. Now 100 divided by the correction factor, which is 50, makes you add 2 units. So you need to add 2 units as the correction factor for the prandial dose. So it comes with a bit of practice. So I don't think that that's a very difficult thing. The idea is that you start with insulin and then the titration becomes very easy. I think we'll go to the next slide. Yeah, the next one. So as I just said, the steps, one more slide. This I have already covered. Yeah, okay. So as I said, first we calculate the total daily dose. Then you divide it between basal 50% and bolus 50%. Bolus insulin is usually divided in 3 major meals. Now you need to measure, you have to monitor. So 3 pre-meals and 1 at bedtime would be the right way. I showed you how you measure insulin sensitivity. As I said, it is 1800 divided by total daily dose. Now, based on the blood glucose measurement and the insulin sensitivity, you will add correctional insulin to the bolus insulin, which I just showed you. And based on this, fasting is what everyone fixes the fasting first. So that's totally dependent on your basal insulin. So which I said, you optimize and you titrate and up titrate the dose and optimize it. So this is a rough way. If it's a patient has an ideal body weight, then this is what it comes to total daily dose. In obese patient, it's slightly more. And if it is a lean patient, it's about 0.3 to 0.4. Next slide, please. Correctional dose, we just covered up. So insulin sensitivity is covered up and accordingly you add 2 to 4 units. This is how it will be. So this can be pasted on the in your non-intensive, the intensive care unit or non-critical ill patient in your ward or in your nursing home. This can be a reference for all your staff to understand it. And do not allow anyone to just manipulate the thing. They have to follow this protocol. Next slide. So to summarize, the in-hospital requirements is a basal bolus regime. There's the ease of titration. There's effective glycemic control. There's almost zero risk of hypoglycemia because you're monitoring the patient. It's very flexible and simple to dose, and it can be used in any range of population. Any sort of profile of the patient, you can use it. Now, just to understand further, next slide, please. What are the factors that can influence your blood glucose control when it comes to insulin-treated hospitalized patients with diabetes? So we have patient characteristic factors where chances of getting hyperglycemia could be because of high insulin resistance or previous poor glycemic control. These are patient characteristics. In terms of hypoglycemia, as I just said, that old age, so you need to not be very strict about your control. Then HbA1c of 7.2 to 7.68 also is okay. There's no problem because here you are more worried about hypoglycemia because remember, hypoglycemia is an individually also a cardiac risk marker. So advanced age, chronic kidney disease, congestive heart failure, duration of diabetes or insulin therapy, food malabsorption, liver disease, malignancies, malnutrition, all this can be factors which can increase the risk of hypoglycemia. These are patient-centric. Next slide, please. Similarly, if the patient's status and therapeutic choices are wrong, you can definitely have hyperglycemia if the illness. Remember, septicemia, critical illness, big diabetic foot ulcers, all those things, wherever there's an infection, you will have that raised hyperglycemia. So you need to treat that and be very cautious, because the moment that starts coming down, patient can go into hypo. So critical illness, decreased activity levels, enteral or parenteral nutrition, increased appetite, recent end of nil per mouth status, release of stress hormones, sudden initiation or dose increase of concomitant corticosteroids. Steroids are one thing where you need to be little strict about it. During COVID, we faced this situation a lot. There has to be a little bit of stricter monitoring of the patient required. The other factors, which are the clinical status related, which affects the risk of hypoglycemia, it is general anesthetic or sedation of the patient. As I said, infection, nil by mouth, reduced or unpredictable appetite, renal failure, sepsis, shock, sudden termination or dose reduction of steroid, and trauma. Next slide, please. Other diabetes management wise, if there are factors responsible, it is excessive insulin dose adjustment and admission, failure to adjust insulin dosing with changing clinical status, inadequate or no blood glucose monitoring, insulin dispensing error, interruption to blood glucose monitoring routine, and overfeeding a lot of carbohydrate rich food. So these are again diabetes management patient factors that increase hypo here would be failure to adjust insulin dosage with changing clinical status. As I said, you treat the infection, your requirement of dose starts going down. Inadequate insulin dose adjustment and admission, inadequate or no blood glucose monitoring, insulin dispensing error, and mismatch between nutritional insulin administration and food delivery. So avoidance of, next slide, please. The most important thing here, which we all need to understand and which we are always going to follow, is that you have to avoid hypoglycemia. So it should be avoided at all costs. Adequate reduction in anti-hyperglycemic therapy when calorie intake is stopped or reduced. Avoid of standard and quote sliding scale. As we just said, insulin without consideration of the patient specific circumstances. Avoidance of overly aggressive attempts to provide tight glucose control. That's one thing which is very important. Glycemic management of intraoperatively or with intensive insulin therapy in critically ill patients. These are the times which you have to be careful. Of course, that is not something, there are intensivists doing it, so that's not a problem. We just have to help them out in terms of taking decisions. Next slide, please. When it comes to blood glucose monitoring, it is important that you monitor it at admission before an OPD procedure or treatment. You have to continue this, appropriate action may be taken with. So frequency of monitoring is important. Patient results of earlier measurements, it has to be documented, and it has to be documented in a way that everyone follows. So there must be standard protocols, like the way we have SMBG charts. In patients with diabetes who are eating, monitoring should occur just before the meal. In those who are NPO, or nil by mouth or feeding tubes, TPN, you have to monitor at regular fixed intervals. Usually it is about 4 to 6 hours. And mode of monitoring in hospitalized patients, conventional capillary glucose testing is the best way. It's very easy. It's not all the time easier or affordable to put a CGM. In fact, that becomes cumbersome. So in fact, admitted patients is not, finger prick is the best way to do it. CGM has been used in inpatient more frequently after the COVID-19. Next slide, please. So goals when it comes to, you have to avoid hypo, you have to avoid severe hyperglycemia, volume depletion, and electrolyte losses. It's important that patient does not go in honk or DKA. Ensure adequate nutrition, assess patient educational needs and address informational deficiencies, and ensure appropriate glucose management upon discharge until patient can be seen by the clinician managing his or her diabetes as an outpatient. So the main goals in patients with diabetes needing hospitalization are to minimize disruption of the metabolic state, prevent adverse glycemic events, return the patient to a stable glycemic balance as quickly as possible, and ensure a smooth transition to outpatient care. Thank you. I know it is a little boring, this topic is, but I tried to do my best justice-wise. I hope, questions I think are to be taken later, right? Right, Amarjit? Thank you.
Sir.
Thank you, everyone, for a patient hearing.
Thanks, Doctor, for your dynamic and remarkable presentation. So now I will request our second speaker, Dr. Puspa Saravanan. Ma'am, are you there?
Yes, I'm there all the time, throughout here only.
Yeah, ma'am. I had seen you. So you will share your slide, ma'am, or I should share your slide?
Yeah, no, I'll ask. Yeah, please, you share the slides. Yeah.
Ma'am, it will be okay because since you are traveling, if you can, just put off your camera, that also will be fine with respect to connectivity.
Yeah. Okay, sure.
No, 1 minute, ma'am. Just.
Actually, I was thoroughly enjoying Dr. Rajul Veswani's talk. So within a short span of time, I was really awestruck the way in detail he talked about each and everything. I don't think so. It's so easy to do. So that talks volumes about his experience in dealing with inpatients with diabetes. So really well taken class.
Thank you.
So the slides are visible now?
Yeah, I can see the. Yes, I can see. Yeah, it's visible.
So from here, your presentation will start.
Sure. So may I start?
Yes, ma'am. Yes, please.
Okay. So thank you so much, first of all, the team Wockhardt for giving me this opportunity. And what I'll talk about is the myths and barriers related to insulin initiation and continuation. So when we say myths, it is mostly on the part of the patient. And when we say barriers, it is at multiple levels. So barriers can be at the level of the patient. Barriers can be at the level of patients, caretakers, their family, friends, who themselves have a lot of stigma related to use of insulin and diabetes. And then barriers at the healthcare professional level. So there also, there will be various stages when a healthcare professional has to initiate insulin. So sometimes, very rarely, it may be because of the lack of knowledge, but most of the time it is because they give way to the patient's myths. So it will always be better to bust the myths of the patients and spend a little more time with the patient and explain them that why it is important to initiate insulin at that point of time. Okay, so everybody has a different experience, beliefs about insulin. So what are the common myths associated? So they are maybe with the use of insulin or with the choice of insulin, right? So patients there will be patients who will be comfortable with injections, right? Syringes rather than using pen. And then there will be people who will be actually asking for pen devices because they are more comfortable to use and less painful. And we have a lot of evidence which says that insulin has long-term benefits. Despite that, the initiation, titration, continuation has shown to have a lot of barriers. So because of this, the healthcare professional and patients delay. So together, there is a delay either in starting insulin or titrating the dose of insulin. As you slowly have to increase the dose of insulin or make a single basal night dose of insulin to twice a day, or change the pre-mixed insulin into basal bolus regimen. So as you have to increase the number of injections per day, as you have to increase the dose of insulin. So patients, they feel that it will be more painful, more uncomfortable in their day-to-day activity. So these will have a poor impact on the long-term complications of diabetes and patient outcome, of course. So we can go to the next slide. So what is one important myth is, patients say that we don't need an insulin early. And then some professionals may feel that, yes, why to start insulin? We can give some other drug like a GLP-1 analogs. And now that the GLP-1 analogs are available in oral form also, so it makes things easier for them. But then everyone should understand insulin cannot be substituted at places where insulin is required. So when it is absolutely essential, we have to give it. And we have to explain the patients about the benefits and what all problems can occur short-term and long-term if the insulin is not started in time. And GLP-1 analogs, of course, they have their own place in the treatment armamentarium. They have their own indications. So they can, how do they work? So they work through various pathways. They reduce the appetite for one. They regulate the gastric emptying. They enhance the glucose-dependent insulin secretion. So when insulin secretion is already there, then only the GLP-1 receptor agonists are going to work. If the beta cell function itself is poor, then we cannot give GLP-1 receptor agonist. In such a scenario, it will not work. So there, insulin has to be given. So that's what I said. Wherever insulin is indicated, it has to be given. And whenever we have to combine with diet and exercise interventions, it does help in reduction in A1C, and weight reduction is also seen with GLP-1 receptor agonists. But however, in practice, we do not see such things happening in all these patients. So it may not be that each and every patient will benefit with each and every drug. But when you take insulin, on the other hand, it is effective in not only reducing the HbA1c to the target level, right? You can increase the dose and bring the blood sugars and A1c to the target levels, irrespective of the level of beta cell function. And studies have shown that after 9 years of diagnosis, a good number of patients, possibly majority of the patients, will need addition of insulin therapy. So sooner or later, I mean, that will not happen on all the patients, but in a group of patients who become more insulin dependent or insulin requiring, I will not call them dependent, they become insulin requiring for a good control of their blood sugar. So over a period of time, as the beta cell function will decline, insulin requirement will increase in a substantial number of patients with type 2 diabetes. Next slide, please. So another myth is we don't need to start insulin early now, again with the GLP-1 analogs. So when we compare, both insulin and GLP-1 analogs have their individual place in the pathway of management of hyperglycemia. But which one has to be used where, that will all depend on the patient's beta cell function, patient's weight, and the status. So like Dr. Meswani said, if a patient has been admitted, there is no place of any other oral drug or injectable other than insulin, and in the right patient at the right time, of course, GLP-1 analogs are important adjuncts to other oral drugs, and along with insulin also they can be given, and they can support both weight loss and HbA1c reduction. So we don't say that they are not useful, but they have their own place in the treatment regimen. However, GLP-1 analogs cannot be used instead of insulin in patients who require insulin. So it is really, really important that we identify the right diabetes treatment to be given to the patient, and it has to be reviewed on a frequent basis in order to ensure optimal outcomes in terms of good glycemic control and prevention of microvascular complications and any acute complication of diabetes, especially when we start insulin and the patient is also on multiple drugs, then the chances of hypoglycemia increase. So we have to keep on monitoring the patient and keep him or her in the loop. Next slide, please. So for many people, long and medium acting analog insulins, they cause less hypoglycemia and cause weight gain. So this is another myth, right? So they feel longer acting insulins will cause less of hypoglycemia and less weight gain. But there is no difference in frequency of severe hypoglycemia between the various analogs in NPH insulin. And overall, hypoglycemia was lesser frequent with long-acting insulin like glargine and detemir. And insulin analogs, they have a slight advantage in terms of hypoglycemia, especially nocturnal hypoglycemia and even pre-meal hypoglycemia, because the duration of action is shorter. So patients who develop pre-meal hypoglycemia because of the short-acting insulin, the conventional insulins. So in such patients, if we use analogs, because of the short half-life of these analog insulin, the short-acting, rapid-acting analogs, there will be lesser chances of hypoglycemia, pre-meal and nocturnal hypoglycemia. And insulin therapy, it is also likely to increase the body weight, not a lot of body weight increase like we see with isolidinones, but in the tune of 2 to 4 kg on an average. And usually it is, the weight gain is seen early in the therapy when we start. And it is not that month by month the weight is slowly increasing. No, it is not so. At one point of time, it will stop increasing. And weight gain in patients on insulin glargine was slightly less than patients on NPH. And then there are strategies to minimize weight gain. And these also should be discussed with patients in whom we are going to initiate insulin periodically throughout the therapy to minimize weight gain. So we can always tell them about lifestyle modification, to take less calorie dense food. So these advices can be given, which can help in reduction of weight. Next slide, please. So what about the patient's perspective? So there is a common patient barrier and perceptions regarding insulin therapy and suggestions of how to address these. So first and foremost is the needle phobia. So we have to, what I find the best way to allay the fear of needles in the patient is, I keep IV needles, I keep IM needles, and then the syringe, insulin syringes, and the pen insulin with the needles. So if you show them the various needles, the IV needle, the IM needle, the needle in the insulin syringe, and the needle used in pen, they will be able to make the difference. And then they will understand that, of course, the insulin needles will not be as painful. And you can also explain, it's easy to explain that it will be not even as painful as a mosquito bite. And mosquito bite at a later stage, it will be associated with itching and edema around that place, which is not so with insulin injection. And then patients feel there may be weight gain. Of course, we talked about that. And then the fear of hypoglycemia. So for that, they need a regular monitoring and not to delay the meal after they have taken insulin. And they also, many patients will have a myth that insulin is only for type 1 diabetes. And then they will say that, am I type 1 or type 2? If I'm type 2, why are you giving me insulin? So then we have to explain that in the inpatient scenario, usually it is not a problem. But when you have to initiate insulin in the outpatient, then you have to explain them that it is important for the good glycemic control so that the long-term and short-term complications, long-term complications can be avoided or delayed. Then they have the fear of how it will impact their lifestyle. They have to take insulin. People who are working, they find it difficult to use insulin in the workplace. So we have to help them and counsel them. Then they feel there are driving restrictions. Then the fear that diabetes is now very bad. This is very common. Whenever you say insulin has to be started, many of the patients, they will start that, okay, you give me a little more time and I will control my blood sugar. But you can make them understand that the beta cell function is very poor now on multiple drugs. The plasma glucose is not getting controlled. So it's not, this is nothing bad, and they should not go into a guilt trip. So most of the time the patients feel guilty that they have to be put on insulin and that they are not taking care of themselves. So that has to be, because that will also lead to depression in the patient. So this has to be talked very well with the patient. And then they also feel that insulin can lead to a lot of complications, and not alone insulin. With every drug you start in the patient, they will always have a doubt if this drug is going to cause any complication, any adverse effects. So we have to explain the adverse effects, of course. But then there was a very cute video recently I saw where they were saying that you talk of adverse effects related to the drugs, but why don't you ask the adverse effects when you are ordering food online or going and buying food in the hotels and eating whatever is available, ice creams, vadas and bhajis. So those things are more dangerous than the drugs which are helping in reducing the complications. And then they feel there may be a personal failure to manage their own problems. So they have to be counseled and you have to spend time with the patients. And then the stigma on the part of family, friends, usually the husband will be refusing, don't start insulin for my wife. And so it has to, the whole family has to be counseled together in such a scenario. Next slide, please. So needle phobia, the concern of fear about injecting insulin is very common, but true needle phobia, that is rare. So phobia is defined as they will have a very severe reaction towards whatever the agent to which they have the phobia. So that is not exactly what we see in day to day, is not a phobia. It is just a small fear. And we have to advise the patient that insulin injections are not considered painful and they are a very small prick. And usually they are less uncomfortable than the finger prick we ask them to do for blood glucose monitoring. Next slide. So weight gain 2 to 4 kg, it can increase, but then appropriate lifestyle and dietary changes. And in type 2 patients, if metformin is not contraindicated and if they are tolerating, we can continue metformin, which will help in keeping the weight under control. And a number of studies, they have shown that there is less weight gain when started on a basal regimen than on a biphasic or basal bolus regimen, because of course the dose of insulin increases with the other regimens. Next slide. So when they feel that the diabetes is really bad, and it can be a personal failure, we have to make them understand that it is bad in the senses because of the disorder, the diabetes, which is a progressive disease. So over time, the body's production of insulin, the beta cell function will reduce. So less and less insulin will be produced. So nothing on the part of the patient is wrong, right? So they should not feel guilty about it. So as the insulin is produced by body, till the insulin is being produced by the beta cell, the medications and lifestyle modifications can help keep the blood sugar under control. But at a time when HbA1c levels are increasing and the blood sugar control is poor, then it may be a reason. If they are following the lifestyle properly, following the drug advice given, in that case, still the blood sugar control is not poor. In that case, they will need insulin, and that means the insulin secretory capacity has gone very low. And there are many effective therapies for managing type 2. Insulin alone may not be there, but so of course you can add insulin to other regimen. And insulin treatment is the next logical step in treatment when other diabetes therapies are not controlling the blood glucose level, or where we think insulin would be the best option for the patient. So that they should understand. And insulin should not be seen as the last resort in optimizing glycemic control, or it should not be like a failure by the patient to control diabetes. So it is not a punishment. They should understand that it is not a punishment, but it is actually, and once they start, you see, when you initially, there may be a lot of resistance on the patient's part, but once the blood sugar control improves, a lot of problems improve. So many patients, their neuropathic symptoms are gone. They reduce, they will be suffering with painful neuropathy. But once you start on insulin, the neuropathy symptoms decrease. With the improvement in blood sugar, the polyuria, the recurrent infections they may be getting, those also get controlled. So then the patients are very comfortable, and then they will not like to reduce insulin. And then there will be a group of patients who will be more comfortable with insulin because and they will ask you to give lesser of tablets. They find it difficult to swallow the tablet. A lot of tablets are written, then they find it insulin as an easier option. And insulin should be seen as an option to optimize glycemic control to prevent long-term complications. Next slide. So in each individual, you should know what is the right time and right place to start the insulin. And if they feel that it will cause further complications, they should understand that complications are not because of insulin, but because of poor control, high blood glucose, which will cause acute metabolic complications as well as long-term microvascular and macrovascular complications. Now, along with other medications which are used to reduce HbA1c level, if insulin is given, it will help in controlling the blood sugar. And if we can control the blood glucose levels effectively, we can reduce the complications. Next slide. So how will it impact lifestyle? Their problem with its impact on lifestyle. So there are a lot of preparations available now. So it is not 100 years back. They should understand 100 years back, the insulin was a cumbersome process and it had a lot of adverse effects, but now it's not so. With advancement in technologies and newer types of insulin with more and more research, we have better and better preparations. The longer acting insulin and single day insulin. So such regimens are available for type 2 patients, and the healthcare professional starting insulin will look at the appropriate regimen for the individual, taking into account their lifestyle, if they are going to drive and what kind of occupation they are in, and if they will be comfortable with multiple insulin or 1 or 2 doses in a day will suffice. And it is likely that insulin will be started as a once daily regimen like glargine at the night time with minimal need for blood glucose testing, because we all know glargine is a peakless insulin and it gives a very good basal control, and even the hyperglycemia peaks at mealtime are reduced with glargine insulin. So once a daily, if it is started and patient starts feeling comfortable and still the blood glucose control is not adequate, we can add on another dose and then they will be more receptive. So in a patient where resistance is more, it is always better to start with a single daily dose. And when glargine, if we have to give more than 20 to 30 units, it is better to split the dose. But up to 25 units, maybe you can give a single dose and it will be quite okay to give a good glycemic control. Next slide, please. So insulin is only for type 1 diabetes. Many patients may have this doubt. So again, progressive disorder. And once beta cell function is reduced, they will need insulin. This has to be explained. And they should understand that initial stages, so they will say, no, earlier I was getting controlled. And when I had diabetes in the beginning, the doctor I went to, that doctor, he used to give me tablets, and one tablet itself, everything got controlled. And now you are giving me so many tablets and you are asking me to take insulin also. So then you should make them understand that with the time, the beta cell function is declining. And so the drugs may not work. And in fact, we can reduce the drugs which are acting straight away on the beta cells. So sulfonylureas can be stopped if secretory function is very poor. And then we can titrate the insulin dose. And the beta cells are tired. If we give them some rest, there may be some improvement in secretory function. So for a short period of time, if we keep the patient on insulin and not give them drugs which are acting on the beta cells, maybe the beta cell function will improve slightly. And there is a limit to what medications can do. And for some patients, insulin is all that we have to, that in order to combat the insulin resistance. So patients with high insulin resistance will need higher and higher dose of insulin to control the blood sugars. Next slide. So the fear of hypoglycemia, it is there in not alone insulin, with oral drugs also. So we have to reassure the patient that most episodes of hypoglycemia will be such that they can be self-managed. And along with that, the family, if the patient is, your patient is working, then the colleagues, their boss, so, and if they are studying, the teachers and their classmates, they should also be informed that the patient is on insulin and what may be the what hypoglycemia features may be like and how to treat it if it is severe. So, and along with that, hypoglycemia episodes can be minimized if we start the patient on a lower dose of insulin, and slowly we can titrate the insulin once in 3 days to a week. We can titrate, up titrate or down titrate the insulin. And a lot of educational packages are available which can be provided to the patients when we start them on insulin, and we can help them prevent hypoglycemia. And not alone that, they need a lot of education, and there are a lot of support groups, and even the pharma companies, they will have a lot of educators who will help in teaching the patient. So not alone, so a lot of times the insulin technique itself may be faulty, right? And we have seen a lot of patients who will be injecting insulin at the same place day in and day out. So even if you give them 1 dose or 4 doses in a day, they'll be injecting at the same place where they find it comfortable. So usually the right-handers will inject it on the left arm. So you have to, every time the patient who's on insulin, you should palpate the arms, the insulin injection site. So it should be inspected and palpated to look if there is any lipohypertrophy. Lipohypertrophy is quite common, and if they keep on injecting the insulin at the same place, the absorption will be erratic. So they will have, the blood sugar control will become poor. So it will become a brittle diabetes. So erratic in the sense, the insulin, after the injection, the insulin may not be absorbed at the right time. So post meal, there will be hyperglycemia, and then at a later time, there may be a severe hypoglycemia. So if such a kind of brittle diabetes presentation is there, always look at the injection site, inspect it, palpate it, and ask them. And you try to continue giving, injecting the insulin at the same place, because over time that place becomes less painful, right? So because of the pain-free site, they continue using that. So we have to check that also whenever we are initiating patients on insulin. Next slide. So now these are the things which can be, this is a checklist. So we can just talk of the fear of injection, and we can give them solutions about the adherence and the complexity of insulin. So we can again, fear of injections, and we can show them the needles. Like I told, you can show them the various needles, and that these are very fine needles. It will not be much painful, and less painful than this. So this is the whole gist of what I was talking all the time. And we can initiate with them with the pens, because it is easy. Dosing is very easy. You have to just rotate the end of the pen for correct dosing, and and all are very soft touch pens. So it is easy to inject, and they should be taught properly by the nurse educator, or even the treating physician can teach them the insulin injection technique. And adherence, long-acting insulins are easy to administer at bedtime, so adherence will be better. And pen devices make administration far, far easier. And fear of weight gain, again, novel insulin formulations associated with lesser weight gain than the conventional insulins, and use of concomitant anti-hyperglycemic therapies like the use of GLP-1 analogs and metformin. This can reduce or attenuate the weight gain. And lifestyle modification, it is very important to help in the weight, weight reduction or keeping the weight under control. And fear of hypoglycemia, the incidence of serious hypoglycemia is rare. Mostly they are self-managed, and novel formulations are there which will have lesser hypoglycemia, like glargine, which is a peakless insulin, 24 hours action.
I'm just sorry for.
I think I missed the slide somewhere.
Sorry for interruption.
Yeah, it's okay, no problem. So we'll come to the stigma of friends and family. Next slide, I think. So novel insulin candidate. So on the part of family and friends, so we can always, with the consent from the person with type 2 diabetes, the care provider and family members can also be asked to come for a session with the treating physician or the educator. We can make them understand. So education sessions, appointments, and more knowledge about diabetes, the drugs which are used for diabetes, and what is diabetes, the progressive nature of the disease. If this is explained to the caregivers also, and along with the patient, it will be more receptive from their end also. Next slide. So clinically, insulin may be the most appropriate choice in a number of circumstances, and already sir has told in detail about the inpatient care. So patients who are symptomatic, who have symptomatic hyperglycemia, so those who have having weight loss, polys, infection, blurred vision, different complications of diabetes, recurrent infection. So these patients will be needing insulin. Then patients who are unable to control the blood glucose despite multiple drug therapy. Right. So in such patients, it will be imperative to start them on insulin. And when other hypoglycemic agents are not helpful in bringing the HbA1c to the target level for that individual. So again, HbA1c level also target varies from patient to patient depending on the age and the other comorbid conditions. So if the target HbA1c is not achieved, in that case, we can always add on insulin. And patients who have allergy or intolerance to other or non-insulin therapies, right? So in such cases, we may have to use insulin as add-on to get a good glycemic control. Next slide. So patients who are limited with oral hypoglycemic medications, especially in patients with renal failure or hepatic failure, in such patients, we will, it is always useful to start them on insulin because most of the oral drugs are contraindicated, especially in the end-stage renal disease and hepatic failure, where it is difficult to control with single drugs. So like oral drugs, we can use linagliptin in renal failure, but then one single drug may not be sufficient to give a good glycemic control. And in patients who have progressive microvascular complications, in such patients, like I told earlier, you people can always, you will find a good improvement in microvascular complications also, especially the neuropathy, which really responds well to insulin treatment. And when concomitant therapies that cause hyperglycemia like steroids are prescribed, so I was talking of steroids in COVID time we used, and a lot of insulin requirements were there, and regular SMBG has to be done. So along with steroids or any drugs which are increasing like antiretroviral therapies and some biologicals, they will increase the blood sugars. So when such therapies are prescribed, regular monitoring of blood sugar and use of insulin dose in proper manner is imperative. And pregnancy, of course, we cannot question it. Pregnancy, if it is not controlled, the blood glucose is not controlled with medical nutrition therapy and lifestyle modification, the patient, and of course metformin also is not working well. In that case, we have to start the patient on insulin. And then there will be patients who will prefer use of insulin. So in such patients, we can start them on insulin. Next slide. Yeah, I finished the slide. Yeah, you can go on to the next slide. Yes, sir. So this is all I would like to talk of insulin. And whenever you have to initiate insulin, some patients will be okay with insulin as soon as you advise them, but maximum and majority of the patients, they will have some form of resistance. So you have to spend time and explain the importance, and most of the time, 99% of the time, they will start insulin. And if the 1% who doesn't start, they may come back again after some time, and then you can restart. Still, when the blood sugar control doesn't come back, when they see that the blood sugar control is not being achieved, then automatically they will agree to be started on insulin. But education will take it a long way. It is very easy to initiate patients on insulin if we educate them well. So thank you for the patient hearing.
Excellent.
Thanks, Dr. Pushpa, for your enlightening and impactful presentation on insulin for its use. So now that question and answer session is open for all. So if there is any query from anyone attendee, so they can ask their query. So both the doctors are available.
Meanwhile, thank you, ma'am. Thank you for that wonderful oration. And
Absolutely.
I think sir, Rajul sir and Pushpa ma'am, happy Doctor's Day, first of all.
Thank you.
And
Thank you so much.
Dr.
Thank you so
Pushpa
much.
was excellent. I mean, this topic is not so easy, and at the same time, we have heard a lot about it, but the way it was covered lucidly, it's so nice. I mean, we really appreciate, madam. It was very nice.
Thank you so much.
Meanwhile, there's one question which I could see from Dr. Nalin, and it's for Pushpa ma'am, it's for you. Is asking which is the best relaxation exercise that a patient, it could be advised to patient for overcoming fear of insulin.
Exercise, I mean, right. So the best, I cannot say exercise, but to allay the fear of insulin, the best thing will be patient education.
Absolutely.
So that is the best exercise. Educate, counsel, and they will understand.
Very nicely said. Yeah. Perfect.
So I think exercise will be on the part of the treating physician.
Yes, ma'am. I think definitely. And one more thing, ma'am. But I'll push this question to you before we go to Rajul sir. Ma'am, we know all the points that you covered. Those are really very essential points. And it took almost 20 minutes for you to cover it all for us. So usually, ma'am, sometimes it does happen in the clinics that time is limited for each of the patient and conveying all these important aspects. What would be your suggestion to everyone as to how to go about it?
So see, diabetes management is always a team management. So it is not one single person, and especially with a country like ours with such a large population, it is not possible for the physician who's treating the patient to sit and explain. Yes, of course, when we are initiating, you have to talk for at least 5 to 10 minutes about why insulin is being started and why it is essential. But then you cannot sit for half an hour, 45 minutes with the patient. So you should have a team of nurse educator. You can take help of your dietitians. So there are, you can always train your, if nothing else, you can train your receptionist. So it is the best way, easy way to train the other staff who's available in your clinic or hospital to make them understand about using insulin. So that is easy, and team effort always works.
Thank you for that answer, ma'am. And maybe I'll pick one of the point from your presentation and I'll take it to Rajul sir. Because Rajul sir, the first slide that you projected was newly diagnosed hyperglycemia. It's not even diabetes, and the mortality is really high. And one of the things that ma'am presented, that once patients are initiated on insulin, their acceptance, and it's a lifelong burden, this kind of things that we usually hear. So, and again, in hospital settings, you mentioned that OHAs should be discouraged and patient should be on insulin. That's the right way to go about it. So, first part of this is, how is the acceptance of the patients? Do they still come to counter that why am I being on insulin? I don't have diabetes. Or maybe it's just diagnosed, why can't I be managed on OAD? And these patients, when they are first diagnosed with hyperglycemia, do you also feel in a long run when they come back and they have a better acceptance of insulin in the course of diabetes?
Perfect. So one more thing which I wanted to add before I answer your question was that what Madam said, the team approach is very much required. But unfortunately, as general practitioners, quite a few people, they are not able to afford to have a bigger team. So one very good thing, like what Dr. Pushpa did just now, we had a very good attendance. So is to do a Zoom or a group of patients education, all the people with insulin, they have the same questions, they have the same interaction, and that club type of thing, if you make it and you call all your patients on a Sunday morning, or treat them with free sugars and something like that, that helps, because the general practitioners who are practicing, the patients are very close to them, so they will definitely listen to them. Only thing is that the way you pointed out, Kunal, that they don't have time, the doctor does not have time. So even if he wants to start it, he's not able to give them that knowledge that is required. So this is one more thing which I have seen working out with people. But otherwise, the best way is to refer to someone who is got the time to treat them. Now, coming to your question, the acceptance, fortunately for people like Dr. Pushpa or me, is more, because if you notice that we see almost 1/3 of the people who come to us already having an existing complication. So they have come with a mental thing that, it's a referred patient coming, or a patient who is only handling diabetes. So it is, I'm totally what Dr. Pushpa said, I endorse it 100%, that you have to have time with the patient when you initiate insulin. And it is the doctor who has to talk, because once the doctor talks, the patient will accept it, and the patient will understand it. we will have to coax, you have to use all your charm, in making them understand, not exactly tell them that this is a punishment or, not to instill fear. Rather, it should be a very nice dialogue and talk, and start setting small goals and targets. That's the best way to do it. Itna karenge, dekho kitna fayda hota hai. Look at your HbA1c coming down. Look at the long-term complications. The other part of your question, I would say that the reason why we are seeing such a lot of diabetics, because if you notice, almost equal amount of patients who are diagnosed with diabetes, we have an equal number who are undiagnosed. They just don't know. So when you come, more so this happened during COVID, means there was absolute denial. हो ही नहीं सकता है. I'm not a diabetic. No. There is no question. वो तो COVID की वजह से हो गया, ये हो गया. See, these people are still in that denial mode. So it becomes very difficult to explain to them, because the maximum number of mortality happened was because they shunned away from going to a doctor or taking the right amount of things. We have done a commendable job, as India has done a great job, but believe me, more lives could have been saved if they would have reached in time, the doctor. And of course, those were the cases. Regarding your other part of your question, whether the acceptance is beautiful. Believe me, once they start insulin, that sense of well-being, the energy levels goes up, they start becoming more, and you give examples of everyone taking insulin, they will accept it. Post hospital discharge also, they are very happy to have one shot of insulin. The number of OHs decrease. And my point about OHA was because we are seeing very bad hypoglycemia till today, Kunal. We are seeing 6 milligram of glimepiride, 1500 of metformin, and 45 milligram of pioglitazone being given because of lack of time or whatever the reasons. Our prescription is given and the tablets are increased every day, just because the doctor or the patient does not have time, or the chemist level it happens. Now look at it, a 6 milligram of glimepiride and you start insulin, you see what havoc it creates, because all these OHs don't go away out of the blood once you stop it. So the first 1 week strict monitoring is very much required, because we've seen very bad hypoglycemia, especially with people with comorbidities. So, all those things, I think this is the right platform for giving such messages that whatever was happening, you have to stop it. That sliding scale thing has to be stopped. Till now, we have seen Maharashtra, interiors, so many places, still this is being followed. Still the nurses are chasing the sugars, and therefore they end up with huge amount of variability. So I think this is a very good platform that you all have found out, and we saw the good attendance. So I think a lot of good messages have gone today. Thanks to Dr. Pushpa and all, and of course Wockhardt.
Thank you for that. Yes, Pushpa, were you making any comments? Sorry.
Yeah, I was just going to say that's what's exactly like Sir said. And then one more thing they should understand it is that insulin is there to bridge the gap.
Absolutely.
To bridge the gap, which is not being done by the drugs alone. So inpatient, absolutely insulin. At the most we add on metformin in patients where insulin requirements are higher and higher, and you have to get the smooth effect. So at the most we add on metformin in wherever it is not contraindicated. Otherwise it is only insulin, and there is not a single patient I've seen who says, no, I will not take insulin in inpatient setup. Never, they never say, because they are already getting so many other injections. So one insulin doesn't really make, and they wait for the insulin for the staff nurse to come and give them that shot. Yes. So and it is very easy. Once they are admitted, once the insulin is initiated at the time of admission, afterwards it is very easy to continue the insulin, or whenever later on or after discharge, if they are put back on oral drugs and at some time the blood sugar control goes poor, it is very easy to restart the insulin in such patients.
See, I just want to add one more thing. What Dr. Pushpa said, it's very important. I want to re-emphasize this. It's usually not the patients. It is the physicians who have a mental block. They are very scared of insulin rather than the patient. The fear of losing the patient because of hypo. They start with a small dose of 8 units, 10 units, and then they stick on to it. They don't optimize it. They don't tell them to do an SMBG chart. So these are flaws which are very easy to correct. It is very easy to address these challenges. It's just that the well-informed general practitioner, once he starts using insulin, look at the volume, look at the number of patients. How can a diabetes specialist handle so many patients? The number of has to be at the primary levels. You all have to take this initiative that the general practitioners should get so well empowered with knowledge that he should be able to handle the diabetics very well. And it is easy now. We've got such beautiful drugs. And one more thing which I want to add in today's forum is that stop thinking about only glucose control, the comorbidities. Start talking about glucose, metabolic, vascular, that type of the whole paradigm has shifted from glucocentric to cardiometabolic, and everything else has to be addressed. And this is no one better than a GP to doing it, general practitioner, a family care physician doing this. So I think such messages should go in such meetings,
Yes, really, I agree with you, and it is a very good initiative by Wockhardt.
really,
This
really good.
right, nice platform.
Sir, just I think one or two more questions keeping
Sure,
time
sure.
in
I'm
proximity.
worried about, I hope people are not getting bored, the time as we've crossed the time.
Yes, sir. So I
No
think
problem.
we'll take two more questions.
Oh,
Sir,
yeah, sure. We are happy.
So
Yeah.
you mentioned about the roller coaster with the sliding scale, and sliding scales in inpatient have always been discouraged. Yet it is there, and I think one of the reasons could be because of not having all the facilities, and it's mainly the nurses who just need that directions. And also, sir, you mentioned adding basal insulin could help to bring down this roller coasters.
Absolutely.
So what is your message?
So first message would be, we need Dr. Pushpa type of patients to educate the nurses and be very clear about what to be done. See, it's not difficult, Kunal. What sliding scale was, it's an age-old, 80-year-old thing. We were doing it when we were in school, medical school. It's gone since more than 20 years now, but still this is continuing. So a good education, it's very easy to train the nurses. None of the nurses wherever I am going, are using this sliding scale now. So the point here is that it is again the role of the doctors to educate the staff and tell them to stop using it that way. Let there be a mock run or a case presentations among the nurses themselves, that what happened to this case, when and how did he go back home well cured. These are things which, let's have an internal discussion among how to handle these patients. So this point number one. Point number two is basal insulin. That's the way to start. See, rather than talking about CGMS, glycemic variability and all those things, the confidence which a practitioner or a nurse should have, or anyone of medical healthcare professional should have, would be to start an insulin. The basal insulin is the best way because it is so safe. It is so easy. It is so easy to titrate. You are just looking at the fasting every third day. You are adjusting the dose. The dosage also is so clear, 0.2 to 0.3 milligram, 0.4 milligram. That's the way to go about it. So believe me, according to me, basal insulin initiation is very easy. And after that, if you are very strict about the OHS, we have superb DPP-4 inhibitors, we have SGLT2, we have got good drugs available for the prandials. So once that is done, maximum you will require will be a basal plus. You may very small bolus you require. But otherwise, if you take care of the big carbohydrate diet that we are all used to it, and that can go across in some way, I don't find insulin therapy a problem in terms of implementing it for the common people. This is my thought. Of course, Dr. Pushpa can add something.
No, I don't disagree with you at all. Totally agreed, sir.
Yes.
So when you start the patient on a small basal dose, they agree, and then of course you can up titrate slowly.
Absolutely.
To get a good control. So once they get the confidence and they understand that it is of course not very painful, then they are okay with insulin, and the well-being, like you told, it takes them a long way.
Yes. And what Dr. Pushpa said, Kunal, it's very important that no patient will refuse. They are all very happy. It's just a mental block, that the doctor is more a culprit, in terms of not able to initiate. And see, look at the time wasted. 7 years, 10 years, 20 years, 15 years, 3 OHS, 4 OHS, and then insulin. There's nothing. I mean, don't forget the glycemic legacy effect. The good legacy effect goes away. We are too late to start. 20 years of diabetes and they've not started. The patient is sarcopenic, totally, absolutely thinned out. And no, the HbA1c is 7. Arre, kya 7? You don't look at the HbA1c after this many years of diabetes. You are not giving them the drug which is giving them the strength and everything, the good clinical outcomes. Look at the health-related quality of life. So these are things which I think should go across in such meetings. That's my thought.
Thank you for that answer, sir. And Pushpa, I'm coming back to you. As sir mentioned, sarcopenia versus there was a topic that you took up, weight gain. So
Yes.
would you like to throw some light on it, where patients should also look at the kind of weight gain that they start getting when they have been put on insulins after the muscle wasting and sarcopenia?
See, sarcopenia is not because of insulin. It is because of poor glycemic control, where the food is not being utilized, whatever they are taking is not being utilized, and slowly they start losing weight. All the glucose is going out, right? So nothing is being utilized, nothing is being nothing is going into the muscle, which muscle, liver, and the fat. Those are the tissue where it is going to be stored. So nothing is getting stored, nothing is getting utilized properly. So everything is going out. So that's why slowly the sarcopenia comes. And another place where we see a lot of sarcopenia is patients who start on all these fancy diets, the keto diet and all. Right? So we forget in the run to give a good, to reduce the weight, we forget that these patients are going in for sarcopenia, which is not addressed. And then with age and lack of exercise is such an important thing. So lack of just walking is not sufficient. They need to have some form of resistance training also from the beginning. And it will not come at an age of 60. You cannot make a person who's already 60, 65, 70 years old to change the lifestyle. It should be started from the very young age. So the healthy lifestyle should be ingrained at a very young age, or at least when they have started gaining weight after school, college, or when they have started going for jobs. So at that spot itself, they should. And most of the patients will come and they will say, I don't have time to walk. I get up, I have to go for work, and I go morning 10 o'clock and I come back at 10 o'clock. Of course, you wake up at 7 o'clock, doesn't matter. You wake up at 6:45. 15 minutes of walking, 15 minutes of exercise is sufficient. So this has to be ingrained early in life. So sarcopenia is not because of insulin. It is because of not taking care of yourself in time. So when your muscle is not being used, it will atrophy. So that sarcopenia is a problem because we are not dealing with it.
In fact,
So-
Kunal, sarcopenia gets treated with insulin.
Yes.
Your correction occurs because
It's an anabolic hormone.
It's an
Insulin is an
anabolic
anabolic
hormone.
hormone. So it is only going to improve things.
Thank you for that answer, ma'am. So maybe the weight gain that the patient initially see is a positive aspect of insulin
Yeah, it is.
therapy.
See,
It
there
is,
will be
it
only
is.
2 to 4 kgs weight gain, maximum 5 or 6, not more than that. So that weight gain is a big stigma associated with insulin. I do not know why. One is the very rare complication we have come across is insulin edema in some patients. But then that edema is not so severe like we get with pioglitazone. The weight gain is also not like pioglitazone, where we see weight gain even up to 10-15 kgs. So insulin will not cause that kind of weight gain.
Yeah.
Right. So patient will look a little plumper, that's all.
Thank you, ma'am. I think when they look plump, they also look really happy. And
Yeah.
one of the points that I think both the speakers mentioned is about patient education and helping them. So we'd also like to talk about that. Yes, that is really important. And being from pharmaceutical industry, we at Wockhardt, we completely understand this thing. And that is why we also offer patient support program. And I'd like to welcome Mr. Vishwa, who heads the marketing over here for the insulins, who could throw some more light on this patient education program. And also, I'd like to invite Vishwa for the vote of thanks and meeting closure. So over to you, Vishwa.
Thank you, Dr. Kunal, and thank you very much, Rajul Meshwani sir and Dr. Pushpa ma'am for such an insightful presentation. So I have a great news to share. And before I share that news, I would like to wish happy Doctors Day to Rajul sir and Pushpa ma'am and all entire medical fraternity
Thank you
for
very much.
servicing this humanity. Thank you very much.
Thank
for
you. Thank you.
And ma'am, we have a great news to share that Wosolin is now completing 20 years. In 2003, we launched Wosolin and put India on the global map of insulin manufacturers. Before Wosolin, insulin was produced by only US and Europe, and India became the third country who started producing insulins. So once again, I would like to thank everyone for supporting Wosolin and for guiding us so that we can complete it 20 years. Thank you, ma'am, and thank you, sir. And Wosolin is still providing most affordable insulin at just 78 paisa per IU. So Wosolin is most affordable insulin available in Indian market. So thank you very much once again for all of you. And now I would like to begin by expressing my deepest appreciation to Dr. Rajul Meswani sir and Dr. Pushpa ma'am for their insightful and thought-provoking presentations. Their expertise and knowledge have enlightened us on a subject of utmost importance. I am truly grateful for this valuable contributions. I also would like to express my heartfelt appreciation to all the delegates who have attended this webinar, and truly your participation have added immense value to this gathering. I extend my sincere thanks to Dr. Amarjit for his exceptional moderation skills throughout the webinar, and I also thank Dr. Sanket and Dr. Kunal Srivastava for powering iTrust webinars scientifically. A special mention goes to our IBB President, Mr. Amrit Medekar, sir, for his vision and leadership that have made this webinar possible. My gratitude extends to LCS Sri Vishnu Shah, who is Cluster Head of Diabetes Business, for his support and guidance in organizing this webinar. And lastly, I would also like to express my gratitude to the entire Diabetes Division field team and all my HO colleagues who have worked tirelessly behind the scenes to ensure the smooth execution of this webinar. So concluding here, thank you all once again, and we look forward to your continued support for Wockhardt iTrust webinars. Signing off. Thank you very much.
Great show. Thank you. Thank you very much. Thank you, Dr. Pushpa.
Thank you. Thank you, everyone.
We had a good time.
Everyone. Bye, sir.
Commendable. With the driving, you could manage such so nicely. Very nice.
Thank you so much. Thank you so much, sir.